Good evening, everyone, and thank you for joining us tonight for Illinois Bone and Joint Institute's 70th virtual YMCA Education Series program with the North Suburban YMCA. My name is Karen Brownlee, and I'm a personal trainer and the adult program coordinator at the NSYMCA in Northbrook, Illinois. This evening's presentation, entitled Understanding Lumbar Spine Conditions, is being recorded so that you will be able to revisit it again. Please feel free to tell your family and friends about it so that they too can view it once it is posted on the IBJI and NSYMCA websites. Lower back pain is one of the leading causes of disability around the world and one of the most common reasons for missed work here in the United States. At any given time, approximately 31 million Americans are experiencing back pain. Lower back pain often results from natural pressure and compression of the spine over time. The good news is that surgery isn't always necessary. Many patients benefit from non-operative treatment options. Tonight, Illinois Bone and Joint Institute's Nirguna Thalla, MD, will teach us more about the causes, symptoms, and treatment approaches for lower back pain. Dr. Thalla is an interventional pain management physician, double board certified in physical medicine and rehabilitation, along with pain medicine. He practices in the Lake Bluff and 2 different Gurnee IBJI locations. In addition to lower back pain, Dr. Thalla specializes in joint and musculoskeletal pain, chronic postoperative pain, chronic pain medication management, facial pain, cancer pain, complex regional pain syndrome, post-herpetic neuralgia, central pain states, pelvic pain, diabetic peripheral neuropathy, neuropathic pain conditions, and migraines. Originally from Michigan, Dr. Thalla received his medical degree from the University of Cincinnati College of Medicine, completed his residency at MedStar Georgetown University National Rehabilitation Hospital in physical medicine and rehabilitation, and his fellowship at the University of Pittsburgh Medical Center, where he was the chief fellow physician in pain medicine. Along with his medical credentials, Dr. Thalla also holds an MBA from the University of Cincinnati Carl Linder College of Business. Dr. Thalla is happy to have landed in the Chicagoland area. With many friends and family located here, and with his Midwest values, he considers Chicago his second home. Dr. Thalla believes in developing longitudinal, individualized relationships with each of his patients to successfully manage their pain conditions. Recognizing that pain can manifest in physical, psychological, emotional, or combined ways, Dr. Thalla understands it is a unique experience for each individual. To address these challenges, Dr. Thalla employs a comprehensive, often multimodal and multidisciplinary approach. He takes pride in finding solutions that focus on improving function, quality of life, and the overall well-being of his patients. Witnessing the significant improvements in his patients keeps him motivated and constantly in the pursuit of learning and adapting new pain solutions and treatment strategies in this dynamic field. Dr. Thalla's first exposure to the medical field was through the lens of a pain medicine physician. He saw firsthand how an effective pain management physician can be a true support pillar for a community. As his medical career unfolded, this formative experience has always stayed with him. The field of pain management personifies what is most important to Dr. Thalla, the creation of a strong patient-physician relationship to tackle and manage challenging problems. This philosophy and treatment style have earned him a rating of 5 stars on Google. Here's one example from James earlier this year. I have been very fortunate to find Dr. Thalla at IBJI. He is a doctor who will actually take time to listen to you and will not rest until he finds a remedy for your problem. I have been happy with all the doctors that I have seen at IBJI, but I am especially impressed by Dr. Nirguna Thalla. If you have chronic pain, he is definitely the best doctor to go see. I just wish I could find a primary care doctor that would devote the time and effort to patients that Dr. Thalla does. And at the end of May, Gloria had this to say: Dr. Thalla is a very kind, caring, and compassionate doctor. Explains everything he is doing. He has helped me tremendously with my back pain. His staff is wonderful too. Highly recommend. And the praise goes on and on. I believe we're in for a very thoughtful, informative program on lower back pain tonight. During Dr. Thalla's presentation this evening, you might find that you have questions for him, which he will be happy to address at the end of the program. Simply type your questions into the question section on your screen, and I will receive them and relay them to Dr. Thalla immediately following his presentation. I do ask that you please keep your questions general as he will not be able to address individual concerns without individual consultation. If you do have self-specific questions, please contact Dr. Thalla via one of the options that will be listed on the slide that will be shown during the Q&A portion of the program at the end of this presentation. Thank you again for joining us tonight, and thank you, Dr. Nirguna Thalla, for your time and effort in putting together this program to help us better understand lumbar spine conditions. Dr. Thalla, please take it from here.
Great. Thank you for joining us, everybody. It is an honor to be able to speak to you all tonight. Thank you, Karen, for that introduction. Without further ado, I want to talk about lumbar spine conditions, just going over causes, symptoms, and treatment. As you know, Karen mentioned, we'll go over some of the treatment options, preventative care, things of that nature. Essentially, we're going to go over conditions that I commonly see in the clinic. So we're not going to be able to go over everything in an exhaustive manner, but we'll be able to touch on some of the most common things that typically affect a lot of our patients, especially those about 30, 40 years old. Okay. And so before we get started with with all the detailed conditions here, I just want to go over the basic anatomy of the lumbar spine. What is the lumbar spine? It's the part of the body that controls and supports your upper body weight. It allows for movement, like various different planes of motion, like bending forward, bending backward, side bending, twisting, things of that nature. So it needs to be a very durable, it needs to be a very strong structure, and also needs to be fairly flexible. So what does it consist of? It consists of 5 vertebral bodies, and these are the bones. And in between these bones, there are shock absorbers, essentially, called intervertebral discs. So there's L1, 2, 3, 4, 5, and then there's these discs that are in between. And this forms essentially what's called the anterior column, or the front column of your spinal lumbar spine. The back part of the lumbar spine, also known as the posterior column, consists of things called your facet joints. And your facet joints are essentially joints just like other joints in the body, but in the lumbar spine specifically, acts as a way to help facilitate bending forward and backwards and twisting. And then the spinous processes back here, these are the bones that when you feel your low back, these are the things that are kind of protruding out there. So this is the posterior column of the lumbar spine. And what this essentially does is this acts as a protective apparatus for the main part of the spine, or the most important part of the spine, which is your spinal cord, which goes through a hollow tube within this protective apparatus. Okay, and the spinal cord, as many of you know, is what provides all the signals to the body to control movement and sensation. And there are small windows in this spinal column where spinal nerves come out of the spinal cord, and these go down into the legs, control your movement, and in the lower body. Okay, and the spinal column is also protected by various different ligaments that kind of reinforce this whole structure. And this is just one part of the spine. As you know, there's the thoracic spine, cervical spine, but we're mainly going to be focusing today on the lumbar spine. So what happens over time? So over time, unfortunately, the lumbar spine doesn't look like quite as it does in this picture right here. Over time, there's a process that takes place. It's called the degenerative cascade. Some of this is natural and inevitable, and it occurs with aging and genetics. Those are things you can't really control. And how this degenerative cascade typically works is you have your normal discs that you kind of develop and kind of have through adult life that have a good amount of hydration in them, which is fluid that sits in the center of these discs that give it a good shock absorbing quality. But over time, these discs start to kind of wear and tear. They lose some of that natural water content and some flexibility. And slowly they start to kind of flatten out and become degenerated like this that you're seeing in this picture. And what happens when this degenerate? That weight has to be transferred elsewhere. So sometimes the bones start to take on more weight than they should. And you start to see inflammation, arthritis start to develop in these bones that are in the front column of your spine. Once that happens, this structure starts to give way and it starts to kind of put weight on another area. So you start to see weight transfer going into the back part of the spine, into what we call the facet joints. And these joints start to take on more wear and tear and become arthritic and become painful. And you can see how this is kind of all one natural cascade that kind of starts with the degeneration of these discs usually. What we can control, there are certain factors that play a role in this that are more controllable, which is lifestyle things like not smoking, optimizing your weight, exercising. All of this can kind of mitigate the development of this cascade. Some people have, strenuous jobs, manual labor where they're putting a lot more physical stress on their body than other people. Doing these type of things in a repeated fashion and doing it with poor posture can aggravate these symptoms and accelerate this cascade. So those are the things that we have to be careful about and try to mitigate in order to kind of prevent some of this from going on. But these are the main kind of causes of a lot of the conditions that we'll talk about. All are generally a byproduct of this cascade one way or another. Okay. So what are the common symptoms that we see in as a result of lumbar spine conditions and low back pain? When a patient comes into my clinic, these are some of the things that I most commonly hear about. And this is where I try to kind of tease what's going on. And symptoms that you have can give us a lot of information. And sometimes I know right away kind of what's going on. Sometimes it takes a lot more of putting things together. So kind of some of the common things that I hear: aching, tenderness, cramping in the low back lumbar area. That can sometimes typically point me in the direction, maybe this is a muscle, this is a tear, this is a strain. That can kind of point me a little bit in that direction. If I'm hearing the word sudden, sharp, that can encompass a number of different things, but then I could start to think about, is this a bony problem? Is this a disc problem, a disc herniation, which we'll talk about? Those could be what would constitute sudden and sharp pain. Burning, numbness, and tingling is a bit unique, but it also can kind of clue me into the fact that maybe there's nerve involvement with your lumbar spine condition. Stiffness is a general overall encompassing kind of symptom from chronic muscle ache and stiffness that can happen after your body starts to protect whatever might be going on. Then I start to listen to where you have pain with different maneuvers, like you're bending forward, or or pain when you're extending your body, or pain when you're transitioning. These different maneuvers, whether it causes pain or relieves pain, can kind of clue me into various different conditions. So pain with leaning forward, that could be more of increasing disc pressure, causing disc pain. Pain with extending, that could be more putting pressure on that posterior column that we talked about, where more arthritis pain in that area. Pain with transitions could be a little bit below the lumbar spine. The sacroiliac joint could get involved, and we'll talk about that. Pain that's worse with prolonged standing, sitting, coughing, sneezing, again, increasing disc pressure might be something that I'm thinking about. Pain that's relieved by leaning forward, like on a grocery cart. We'll talk about that with lumbar stenosis. That could clue me into what that specific condition, for example. Then I look into some things that are more what we call red flag symptoms as clinicians. These are more rare, but it's something that we got to pay attention to, because it starts to give us an indication that this is not just a mechanical issue. It's more of a nerve issue, and now we're thinking about nerve damage and things that might go beyond the realm of non-operative care. We're talking about nerve damage that could be affecting your bowel bladder control, weakness and progressing weakness in the legs, could be symptom of serious nerve damage in the lower part of the spine. Groin numbness, saddle numbness, basically numbness in the area where you'd sit on a bike. That could also be more of a red flag sign. And then generally, when back pain is accompanied by fevers, chills, unexplained weight loss, we start to think maybe is there an infection going on in the spine, in the fluid in the spine, like an abscess or another type of infection. An unexplained weight loss when accompanied with back pain, we always have to think about possibility of tumors or cancer. But again, these are all the more rare symptoms, but that we see every now and then. But these are the other symptoms that we typically see more frequently. So let's go over the conditions one by one. The most common conditions that we see in our clinic, we'll go over 6 of them today. There are more, but we'll go over some of the common ones that I typically see. So condition number 1, a lumbar muscle strain. It sounds simple, but it can be fairly agonizing and painful for a lot of patients. So what's happening with a lumbar muscle strain? Basically, due to awkward movements, improper lifting, twisting, you're overstretching your muscles, and that could cause the tear in the fibers of your muscles. So not always a tear, sometimes just a strain, which is just stretching it beyond where it should be stretched, or where you're typically used to it being stretched. And when this happens, the muscles react by, there's an inflammatory reaction that occurs, that swelling that occurs, and this can lead to pain that is often described as aching, dull, but in the initial stages can be very sore, very, very tender. And patients often describe it as spasms and cramping. But the key part is to know that this is typically not pain that goes down the leg. That pain that goes down the leg is more nerve involvement. This is very localized into the region of the lumbar area. And it's typically usually, one side or the other, and it's not necessarily always midline. Midline is more of the spine itself. This is kind of on one side or the other where the muscles typically are. Okay. And that's condition number 1. Condition number 2, very common common one that we see in clinic, is a herniated disc or a slip disc. So your disc, healthy disc, this is kind of a cross-section view of your disc now. You have the inner gel material called your nucleus pulposus, holds a lot of water content, gives it the shock absorbing quality, and then it's surrounded by these fibers that protect it and keep it all contained within. But with a herniated disc, this can happen with wear and tear, but also with a sudden injury in some younger people who do some lifting and things of that nature, where you get a tear or a rupture in that disc. And this rupture can leak the contents of the inner part outside towards where the nerves are. And this can result in chemical irritation. So the nerves don't like to see that material from the inner part of the disc. It gets very inflamed, very irritated. And when the nerve gets irritated, it sends pain signals throughout the entire nerve, throughout that nerve distribution, going all the way into the leg. That's when you're experiencing more of that numbness and tingling, which people describe as sometimes pins and needles, jolting, electricity, shooting sharp. Those are some of the common phrases that we see when we talk about a herniated disc. When this compression is serious enough from a herniated disc, it can cause some weakness. It can cause the nerve to stop sending proper signals and causing weakness in the legs as well. Sometimes coughing, sneezing increases this disc pressure and will exacerbate those symptoms as well. Third condition that's very common is what we call facet arthritis. So the facet joints sitting in the back part of the spinal column, the posterior column, these joints facilitate movement like bending and extending. They're just like every other joint in the body. They're very small, but they're just like your knee joint, your hip joints. They have like a lubricated cartilage that sits in the middle, and there's a capsule that surrounds it. But over time, with the degenerative cascade, this area could get arthritic and painful. And what symptoms do we see when this happens? We see, symptoms that are more confined to the low back, more confined to the middle of the spine. Sometimes the pain refers out to the upper buttock region, but typically doesn't go below the legs. There's not usually numbness and tingling. It's very mechanical in nature. People complain of sharp pains when they're twisting, bending, extending. This could be as a result of the arthritis in the facet joints. The fourth condition that's very, very common, especially as we get, past 30, 40, we're starting to get to age 50, 60, 70. I call this condition kind of more of an all-encompassing condition because it's not just a result of any one thing. Lumbar spinal stenosis, essentially narrowing of where the spinal cord and nerves sit. This could be due to the disc issue itself, then the arthritis that we talked about builds up, and all that kind of accumulates, and the space that the area is protecting, originally was protecting it, is now becoming the source of the issue itself. It's kind of squeezing down on the central canal here. And that causes irritation, inflammation in that area. So what symptoms do we see with spinal stenosis? So the symptoms that we see is something called neurogenic claudication. What that essentially means is when patients typically have pain with prolonged walking, or sometimes if the stenosis is bad enough that you only need to walk 3, 4, 5 minutes and you can have symptoms. Patients describe heaviness in the legs. They describe a cramping sensation. They describe when they're walking in a grocery store, for example, patients describe the need to lean forward on a cart in order to be able to relieve some of the symptoms. And the reason that they're doing that is the body is naturally trying to open this space up, give the nerves a little bit more room to breathe. I call it kind of like you have a pipe, sediment's now built up in the pipe, the water is not kind of trickling through as much anymore. So that's kind of what you see with lumbar spinal stenosis. So that heaviness can extend all the way from the buttocks down into the calves. Sometimes it's just back pain. Sometimes, interestingly enough, or sometimes I call it atypical back pain when you see a lumbar spinal stenosis. It's not always just in the legs, so it's something to keep in mind. Condition number 5, another very common condition we see in our clinics, is sacroiliac joint dysfunction. It's essentially the sacroiliac joint sits a little bit below your lumbar spine, as you can see here. It acts as a bridge from the lowest part of your spine, the sacrum, to now getting into the hip joint, the ilium. So there's a joint space there called the SI joint. And this joint, just like any other joint, is prone to trauma, injury, overuse, poor posture, and it can take on stress and inflammation. Sometimes when it moves too much, sometimes it moves too little. Both things can cause pain. Sometimes rheumatologic conditions here can cause pain, and usually you get pain on both sides when it's a rheumatologic condition. When it's more just mechanical in nature, we expect pain just typically to be on one side. The symptoms here, typically right below the waist. A lot of my patients can point using just one finger, point right to one side, like upper buttock, below the waist on either the left or the right. And that's typically where that inflammation in that SI joint is. It can act as a masquerader for some of the other conditions we've talked about. It's a little bit more tricky to diagnose. It can be anything from sharp, stabbing, dull to aching. Sometimes there's a radiating pattern to the buttocks, hips, and groin. Certain maneuvers like twisting, bending, all that stuff could provoke it. So it's a little bit more tricky to diagnose sometimes. And sometimes the best way to diagnose sacroiliac joint dysfunction is simply to put an injection into the joint, put in some steroids, see if we can reduce the inflammation. If there's a dramatic improvement, that kind of cinches our diagnosis for sacroiliac joint dysfunction. Condition number 6, the last condition that I'll kind of go over with our presentation today, is vertebral compression fractures. This is something I don't see uncommonly, especially in the elder population once you're getting into 60s, 70s, 80s. Essentially, what happens here is a condition is a predisposing condition of osteoporosis. Bone here is this bone is pretty dense on a typical basis. It's very dense. Osteoporosis essentially means the bone is getting more porous. There's more channels through the bone. It's just a weaker structure in general. So in our elder patients who have osteoporosis, sometimes a simple mechanical fall, or sometimes there's not even a predisposing fall. Sometimes they just kind of develop this where they get a compression fracture in the vertebra. So what does that mean symptom wise? It can mean like a severe sharp pain kind of in the midline aspect of the spine. Usually can point to it with one finger, generally with one finger. Doesn't radiate a whole lot. It can kind of radiate in like a band-like fashion. Sometimes the muscles around it get tight. But there's typically not nerve involvement unless the compression fracture has kind of extended beyond the confines of the vertebral body and kind of get into the spinal column, in which case there could be significant nerve involvement. But generally speaking, a lot of the patients we see is just pain right at the level that the compression fracture has occurred. And we'll kind of go over some treatment options for this as well. So how do we find out the problem? You know, a patient comes into clinic. There's a number of different spine conditions that are lumbar spine conditions that are out there that can cause these symptoms. Here we only highlighted six of the major ones, but there's several others. It's a process. So everybody's different. It's an individualized approach. And it typically starts with obtaining a basic medical history. So I ask you about your symptoms, kind of get that history, that, you know, some of the things that we already discussed, seeing what makes it better, what makes it worse, getting that information. Sometimes the medical history is sufficient enough for me to get a good understanding of what, you know, might be driving what's going on. But then, you know, physical exam comes into play, where I'm looking at your strength. I'm looking for any potential nerve involvement, loss of sensation in your legs. Reflexes can also point to nerve involvement. Range of motion, if you look like you're struggling with bending forward versus bending backwards, that can give me more information. So this is a diagnostic process that occurs when I see you in the office. And sometimes that's not that's not sufficient. You know, some of these symptoms and some of these conditions have a lot of overlapping features, so sometimes it's just not sufficient, and we need to do more imaging tests. And sometimes we're not responding to initial therapy, so we got to do further tests using X-rays, MRIs, CT scans, getting a clear picture of the bones, discs, nerves. MRIs typically do a great job of looking at all that soft tissue and giving us a good indication of what might be the culprit for your condition. Lastly, there's other tests. One of the tests some of you might be familiar with is an EMG test. It's a test that tests the kind of like isolates muscles and nerves in various parts of the body, and can kind of pinpoint, you know, is this actually coming from the back, or is this further downstream in the nerves that are in the legs itself? Sometimes getting that isolated information can give clinicians a better idea of how to kind of manage things. So now let's get into what treatment could look like for some of these spinal conditions in the lumbar spine. So my main focus is non-surgical care. We have every bit of continuum here at IBJI, from non-surgical care to operative care, but I predominantly focus on non-surgical care. And non-surgical care, typically, we try to be as conservative first, and then we kind of take it and escalate it in a stepwise fashion, unless there's a more severe condition or severe symptom that where we need to jump some of these steps and kind of go to more something more invasive more quickly. But generally speaking, we start with conservative care, and that can be as simple as, you know, activity and lifestyle modifications. A lot of low back pain conditions that we've talked about, especially in the acute phase, where it's, you know, it's been less than a couple of weeks since your symptoms developed. Sometimes just rest is all you need. The rest, you putting ice to reducing inflammation, reducing swelling, sometimes heat to help facilitate muscle stretching and keeping your muscles loose and not so stiff. Those alternating between some of those things and reducing any harmful activity is sometimes that's all you need, and that'll take care of the problem, and you'll kind of get back to your normal function. Making adjustments to your workplace setting or your home setting or your exercise setting, using supportive chairs, desks, proper lifting techniques. Optimizing your weight, of course, is one of the best ways to reduce pressure on your spinal discs and joints. And then quitting smoking is one that I like to harp on, because smoking does really dehydrate the disc and can accelerate that degenerative cascade. So some of those are definitely always pretty much touched on for most of my patients. Then we kind of go from there. We talk about physical therapy. Physical therapy is a good way to develop a relationship with a physical therapist who can kind of guide you and provide you with treatments to improve your strength, range of motion, flexibility, stretch muscles, do things like traction, which reduces tension on the nerves, improve your posture. All these things can not only help you during a pain state, but also can prevent future pain states, future exacerbations. Building up your core strength. The core acts as a nice brace to your lumbar spine. So doing that with physical therapy and exercise is important. And this is all very personalized because everybody's in a different area when they come see a physical therapist. Sometimes people are in excruciating pain. Sometimes people are just now recovering. So it's very personalized. And then sometimes we go to medication management if necessary. Anti-inflammatories are very commonly used in low back conditions, lumbar conditions, because a lot of lumbar conditions are inflammatory in nature. So we use things like ibuprofen, Tylenol to reduce inflammation. Sometimes you need more prescription strength grade of these medications, which there are a whole host of those anti-inflammatories. And then there's other types of medications like muscle relaxers. Sometimes when pain becomes more chronic or there's more nerve pain than inflammatory pain, we start to get into medications like gabapentin, some of you might be familiar with, or Lyrica. And these medications target nerve channels and reduce painful nerve transmissions. And antidepressant medications, how they work in chronic pain and pain that's kind of lasting a little, extending beyond the typical window that we like. Basically, it upregulates good chemicals in your body, downregulates bad chemicals, and this overall reduces pain symptoms. And those need to be specially titrated, so that's done under the care of an experienced physician. Other non-surgical treatment options. So injections, that's one that's very commonly done as an interventional pain physician myself. We do these injections all the time to help reduce especially acute pain symptoms. Sometimes we do this in chronic pain symptoms as well. Typically have better results with acute pain and reducing acute inflammation than we do with chronic inflammation. But it's something that's a strong tool in our tool belt to help kind of treat lumbar spine conditions. So what is an epidural steroid injection, for example? Epidural steroid injections are basically, we go into your epidural space, which is the space right above where the nerves sit in your lumbar spine. So we go through the posterior elements and into that epidural space, and we deliver. And some of you may have heard of that because it's based on labor epidurals, but that's the space that's there. And the steroid is the medicine that we put in to reduce inflammation there. This could be done for stenosis, herniated disc, various number of conditions. Typically, you have leg and nerve involvement when we're doing an epidural steroid injection. These are typically done in office, 5-10 minutes. We do a numbing medicine before. We use a live x-ray camera, fluoroscopic camera to guide exactly where you're going. You're laying on your stomach for that procedure. There are other non-surgical options that involve injections, and these include nerve blocks and ablation. Some of you may have heard of these. And this is typically done to treat arthritis-related pain, not so much the pain from a herniated disc that's causing sciatic nerve pain that's going down the leg. It's really for more of that low back pain that's just at the waistline, essentially, when it's exacerbated by bending and twisting. So what happens here is it's a multi-step process. So you have your nerves that come out of the of the spine here. You have very small branches called your medial branches that go to that area of the facet joints, the joints that have since become arthritic. And what these arthritic joints do is they just, and these medial branches do is they just take pain signals from these arthritic joints and just send it to your brain saying, hey, this area is painful, it's sharp, it's bothering me. But these nerves don't control any of the function in your legs or anything like that. So what do we do to these nerves once they start just constantly sending these pain signals? We try to block them. We do a procedure called medial branch block, and we put an anesthetic medication there to block the pain signal. It's a temporary intervention. It's something that's done where we look for about 50–80% relief to see if you typically go about doing the things that you typically do that causes your pain. And if you get significant relief, we do this injection twice, and that's essentially a modern insurance requirement to do that. And if you get good sustained relief from a nerve block, we do something called an ablation. An ablation is we essentially take a small probe and go back to those same nerves that we did the nerve block on. And instead of just putting a numbing medicine there, we put a heat treatment. We use radio waves to deliver heat signals to essentially destroy those nerves for a short period of time. Those nerves do regenerate over 6 to 12 months, but in the 6 to 12 month time frame, the destroyed tissue hopefully will stop sending pain signals to your brain, and then you can get some pain relief, looking for about 50–80% pain relief for that extended 6 to 12 month period before the nerves do regenerate. Again, this is also done usually typically in an office setting. Then there are more minimally invasive procedures that, somewhere that land between injections and surgery, but they still go through like a percutaneous channel. So you're not kind of getting cut open where there's like suturing and all that stuff going on. So example of one minimally invasive procedure is a kyphoplasty. And this is to treat the vertebral compression fracture that we talked about. Essentially, there's a probe that goes to the area that you have a compression fracture, and through this probe we take and we put in a balloon system here, and we expand the balloon so the vertebral compression fracture has collapsed this vertebral body. So what the balloon does is it opens up and it restores some of that height that's collapsed. And when it restores that height, it creates this cavity. So we take the balloon out, and in that newly formed cavity, we put in a medical grade kind of cement mix that goes and fills it up and acts as like an internal cast to that compression fracture. And that should help with painful compression fracture pain, and also act as a way to restore that vertebral height that you could potentially lose when you get a vertebral compression fracture. So that's just another example of minimally invasive procedure. There are several other ones that treat several other conditions that we don't have the time to necessarily go over today, but are all within the wheelhouse of an interventional pain physician at our practices. So general things to think about when it comes to non-surgical care. A lot of conditions do improve in a 4 to 6 week time frame, especially things that just have arisen. They can improve with non-surgical treatments in 4 to 6 weeks. That's something to be encouraged by. And these are typically exacerbations that we can get under control. Everybody's treatment plan is different. Not all approaches. Sometimes one medication works for somebody, doesn't work for somebody else. Sometimes an injection works well for one person, doesn't work for somebody else. We see that all the time in our field. Key thing is that we have to collaborate across fields and across specialties, whether that's physical therapists or whether that's a nutritionist that's trying to optimize your weight, whether that's chiropractors or acupuncturists or various different specialists that work in the lumbar spine space. We all have to collaborate, kind of work together to formulate an individualized treatment plan that works best for you. So now that we've talked about, treatments, causes, conditions, I want to talk about just kind of general prevention and maintenance of good spinal hygiene so that hopefully you can kind of avoid some of these conditions. ultimately that could develop. So one of the key areas of spine hygiene is sleep. So it's important to get good sleep for a number of different reasons, but it's important to get proper positioning when you sleep to keep your spine in a nice neutral form, so that you don't develop accelerated degenerative cascade of symptoms. So I kind of developed this table here a little bit to kind of show which type of mattress is appropriate for which type of sleeper. So for someone who tends to sleep on their back, this is typically the best position for the spine, but not everyone can sleep in this way. We typically recommend a medium firm to firm mattress. This kind of helps maintain that low back and pelvis in the body's typical natural curvature, and you don't get gaps where you're kind of sinking in or anything like that. If you're a side sleeper, there's a little bit more give to it. Medium soft to a medium firmness in the mattress, so that your shoulders and hips can kind of align when it sinks down a little bit, and then that can keep your spine aligned. And that relieves the pressure points along that area. So when you're a stomach sleeper, typically not a good position for your spine, because when you're sleeping on your stomach, you're really what we call extending the curve of the spine, arching it, and kind of creating more pressure where you shouldn't be doing that. But if you do sleep on your stomach, we recommend as firm of a mattress as possible to counteract that arching that you're doing, and keeping your spine as neutral as possible, or minimizing any strain. Other things to look out for spine hygiene is just the way you're standing. You want to manage, when you stand, you want to manage gravity efficiently and keep your muscles working as minimally as possible, so you don't get strains and spasms and things of that nature, and you're not accelerating any degenerative issues that could be developing. So it starts really from the top down. So we starts up high in the neck, in the cervical spine region. You want to make sure that you're not rounded, your shoulders aren't rounded, and your head isn't leaning forward. This can happen, it's very common in our society. We're always on the computer, we're always kind of leaning forward, doing kind of crunching like this. You want to be very mindful of whenever you're doing that, because you don't want it to make that a habit. You want to keep your shoulders relaxed, keep your chest up, and practice some chin tucks, and then that will kind of keep your head in proper alignment, and that can kind of carry forward all the way down to the lumbar spine. Your core is, again, very important. It acts as a brace. Gentle abdominal muscle contraction can also keep the spine in a nice neutral position. And when it comes to your lower body, keep your knees kind of slightly bent, hip width apart. It balances your weight evenly across. It keeps you in a proper standing posture. An easy way to kind of do this is just to simply stand up against a wall and put all the parts of your body, your butt and your shoulders and your head up against the wall, and that's typically your proper standing posture. You have a little bit of space for your hand to slide behind your low back. Okay. What about proper bending and lifting posture? This is important, especially for people who are doing consistent manual labor and moving boxes, things of that nature. You want to essentially keep your back as neutral and as straight as possible when you do that. You want to avoid that C-shaped curve when you're bending and picking something up. You want to bend with your hips and your knees like you're sitting down in a chair, simulating sitting down in a chair. And you want to keep, in order to do that, you got to keep a wide base in your legs. And that will help you maintain balance as you're going to bend. Engaging your core, that's, as you can see, the common theme: strong core, strong core, strong core. You want to make sure your abdominal muscles are tight and able to stabilize your spine and pelvis through these various ranges of motion. So it acts as a natural brace. Keep the object close, don't extend it all the way out. When you extend it all the way out, you're increasing the level of strain. And then when you come back up from the bend position and you're lifting something, drive your legs up, use your glutes, use that as a hip extension maneuver to get you upright, instead of kind of creating that C when you're coming back up for your spine. So if you can maintain this posture throughout the lifting motion, that means you're doing a good job of reducing strain on your low back. Okay, so this kind of is a general overview of causes, symptoms, conditions, and prevention. I'll definitely love to open it up to questions, and I want to thank you guys for your time, and look forward to seeing some of you guys in clinic, of course.
All right. Thank you very much, Dr. Thalla. All right, we have a lot. You ready?
Sure, sure.
Okay. All right. So you've covered a bunch of people's questions. You covered non-surgical treatments for spinal stenosis and about epidurals. One question regarding epidurals: what are the risks of getting epidural shots, and how many can a person receive in the course of their life?
Sure. When it comes to risks, whenever you read risks of something like an epidural steroid injection, you're like reading a back of a pill bottle, there's just a number of different things that are listed. But the things that I want people to focus on is epidural steroid injections are generally, by and large, it's very safe, done by an experienced provider. So anytime you put needles through skin, there's a risk of bleeding, infection, nerve injury. We take all the necessary precautions to minimize that. If you're on blood thinners, you come off blood thinners, there's an active infection, we don't proceed with the procedure. But the general side effects that we typically see in a clinic setting is a reaction to the needle. And when you're getting a blood draw, you sometimes get the same type of reaction when there's an epidural steroid injection. People get anxious and get sweaty, and sometimes they can faint. But that's, again, very rare that happens. It's typically a 5-10 minute procedure that we do in clinic. Some of the other side effects, especially for diabetics, could cause a small spike in your blood sugar that typically comes down. Steroids in general, when introduced into the body, can cause changes in appetite, changes in your sleep schedule, typical sleep hygiene, but that again is typically self-resolves. The one that people are most worried about is nerve injury related to epidural steroid injections. And I don't know the exact number, but I believe it's like 1 in 150,000 where you see some sort of nerve injury as a start of epidural steroid injections. When it's used, when there's a fluoroscopic guidance, which is X-ray guidance, see precisely where you're going, it really reduces any of these more harmful side effects.
Great, thank you very much. That's super helpful. Okay, is it common to have daily back soreness even with physical therapy and exercises?
Sure. Yeah, and I forgot to ask the other part as far as the number of epidural steroid injections. Typically, right. 2, 3, typically spaced out every 3 months or so, is what we see for is what the insurance requirement is, and a good safety margin. We really want to see that you get at least 50% relief for about 3 months to make sure that epidural steroid injections are worthwhile to kind of repeat again.
So it's 2 to 3 in a lifetime, or 2 to 3 a year?
No, 2 to 3 a year. Okay. But we do one and we see how you do, and then we go to the next. We don't plan out that we're going to do 3 or 4 a year. That's not, you typically just do one and go from there.
Okay, got it, super. All right. Okay, so then the question about, is it common to have daily back pain even with physical therapy and when doing exercises?
Yeah, so sometimes, unfortunately, back pain can become chronic in nature. A lot of the conditions we talked about, they sometimes can resolve in the 4 to 6 week time frame. Sometimes they can become chronic, which is greater than 12 weeks. That's where we get into other forms of management. So physical therapy, sometimes when your body is hypersensitized and you have a lot of chronic pain, sometimes physical therapy can be an aggravating factor. So we typically have to shoot for other strategies, whether that's the injections or the medication, or simply just getting a lot of rest as a way of kind of mitigating those symptoms. And then we introduce physical therapy afterwards to kind of recondition the body. So it just depends on the amount of pain someone is having and how interfering it is with their daily life.
Gotcha, that makes sense. Okay, thank you. You mentioned a little bit, very briefly, chiropractors and other like working with different healthcare providers. How do you feel about chiropractors, and what are your thoughts on their benefits? Potentially being harmful, being helpful, etc.
Sure. I mean, I don't have anything directly negative towards chiropractors. I've collaborated with some chiropractors myself. I think everybody has some role in the spine space, but it's just important to maintain a very collaborative relationship. I think that's the biggest thing. I think communication between providers is paramount. When one person is doing one thing and one person is doing something completely in opposition, that's where patients get frustrated, patients have setbacks, and things of that. So chiropractors, I typically would recommend a physician evaluation first, a physician evaluation to see what the underlying condition is, see what would be appropriate as far as manipulation to that area before you seek out a chiropractor care. Chiropractors can be a good way of supplementing some of the care that some of the physical therapy that we often prescribe, but sometimes if there's not good communication, it can work negatively and not be productive. So it's just all about that communication between providers.
Great, thank you. And that communication, is that reliant upon the patient to be the one to communicate, or it sounds like you've worked in cooperation with chiropractors, so you would be willing to communicate with them as well?
So it can be challenging. There's no doubt about that. It can be very challenging because not all of our systems are integrated. Not everything can be easily, not all documents are easily transferable between electronic records. But
Right.
What I typically recommend is if I'm not familiar with the chiropractor myself, I ask for the patient to bring in documentation of what the chiropractor may have done, especially if that's something that they've done before they're seeing me. If they're seeing me for advice, I would typically send them to a chiropractor that I already have familiarity working with so that I can get that information back and forth more easily.
Great, that makes sense. Thank you very much. Okay. Is there something you can do for someone who would be allergic to contrast dye who might need an epidural?
Yeah, so contrast dye allergies are relatively uncommon when it comes to spine procedures. The contrast allergies that most people are referring to are IV-based contrast when they're getting MRIs and things like that. It's introducing a lot more contrast into the body. The contrast in the spine is a very small amount, so it's very rare for it to cause a reaction. But if it does, we still want to be mindful of that and prevent any of that from happening. So what I typically, some injections can be totally done safely with just X-ray without contrast. So there are a subset of injections that can be done without contrast. The ones that we absolutely need contrast for, we pre-treat to reduce the risk of any allergic reaction. So what we do is a very standard dose of steroids. Typically takes care of any sort of potential reaction from a contrast allergy. It's very I've done it several times myself, where we give a patient a medication regimen to take before they come in for their injection, and we've never had any issues afterwards giving the contrast for those patients that had those allergies.
Oh, that's fantastic. Great, thank you. Good news. Wonderful. All right. What are your thoughts on inversion tables? And if you're in favor of them, when would you recommend using them?
Yeah, in inversion tables, again, I'll recommend a physician evaluation first, just to make sure that someone has an MRI level of understanding of your spine. Basically, where are the nerves getting pinched? What's the degree of the potential stenosis? Is this very critical or is this not critical? You want someone who gets an appreciation of that. But inversion tables, they act in a way where they kind of open up some of the spaces where the nerves are getting pinched. It's usually a temporary measure for a lot of people. In my practice, so what I see, they get the nice relief and the nice benefit for a little bit of time. Essentially, it's opening up spaces because the gravity is working against the spine and it's creating it's opening up those channels. But once they go back upright, sometimes they have some duration of benefit afterwards, but sometimes it just kind of goes back to the same level of symptoms before. So in my opinion, it doesn't really do much harm for vast majority of people. So it's something that you could try to see if it works for you.
Great. Okay. Thank you. Have you worked with PRP injections and plasma injections?
Yeah. So that is an offering at Illinois Bone and Joint as well. There's the whole subsect of treatment called regenerative medicine. So instead of just putting steroid injections, which is what we talked about today, steroid is an inflammation reduction. The idea behind regenerative medicine or PRP injections, which is plasma that you take from your body, and you put it in, you constitute it into an injection, and you go to an area where there's maybe some tissue damage, and instead of reducing inflammation, you're actually creating a situation where there's irritation to that tissue. So what we are doing there is you're inviting all these growth factors to come in and start to create a healing process near those tissues instead of just reducing inflammation. That healing is regeneration. So that's why it's called regenerative medicine. So we do those PRP type of injections. The evidence on that stuff is a little bit more variable than something like a steroid injection. But we do have patients who do those and do really well with those as well. So it's just all individualized in that respect.
Great, great, that makes sense. Thank you. Do you offer minimally invasive procedures for patients that are candidates for SI joint fusion?
Yes. So SI joint fusions are typically when you have sacroiliac joint dysfunction that hasn't responded to injections, that hasn't responded to, I do typically do a regenerative treatment for SI joint dysfunction because SI joints, the sacroiliac joint, the ligaments can get disrupted, and sometimes those ligaments need to have be treated on so that they can kind of develop some regenerative aspect to the tissue. If those don't work, if the steroid doesn't work, if there's a significant amount of mobility in the joint, sometimes fusing the joint is a last resort option. It's not something I do very commonly, but it is something that we do and do offer. Essentially, we want to reduce any of that mobility that's in that joint and stabilize it in one spot, so it's not causing that friction, inflammation, and pain that can be a pain generator for some people.
Great, thank you. Thank you. Very helpful to know. Good. Do you recommend any natural supplements to help maintain spinal health?
As far as natural supplements, there are some of the basic ones that I do definitely recommend that are safe for most people to take are just calcium and vitamin D, and that's for osteoporosis prevention. Maintaining good bone density, those two supplements can do a great job for doing that. You just got to be consistent with it. I would also recommend patients getting their vitamin D levels looked at, making sure that they're not deficient. Vitamin D deficiency can cause a whole host of different issues, including pain as well, and from osteoporosis. So taking those two supplements are good. Sometimes magnesium is a good one for nerve health that typically can be helpful. But you got to be careful with magnesium because you got to take it in a set way so it doesn't kind of cause any heart issues or anything like that, because it can be involved in that as well. So
great, thank you, thank you. And I had listed a list of the different things that you work with, your other areas of expertise, but someone's asking specifically to problems of the middle back. Do you also work with people with problems of the middle back?
Right. So we focus mostly on the lumbar spine today, but we as a spine physician look at every single aspect of the back. The cervical spine, the middle back being the thoracic spine is another area that it's not as common of a pain generator as your lumbar spine or your cervical spine, but it can cause problems, and it's definitely an area that we do treat.
Great, thank you. Is there a role, does massage therapy play a role in treatment of lower back pain?
Yeah. Anytime you have lumbar spine conditions, there's a good chance that you have muscle tension, because muscles protect they kind of act in a way in which they guard some of the underlying conditions that you have going on, and that guarding is a natural way of the body protecting that area, but it can also manifest as stiffness, soreness, aching, all those symptoms. And massaging is a tried and true way of kind of helping relieve some of that muscle soreness and tightness. It's usually a temporary relief, but it's something that if you do on a routine basis and you work on it in conjunction with stretching and improving your flexibility and range of motion, can really help go a long way in helping you.
Super, awesome. All right, thank you very much. I want to let you know there's a whole bunch of thank yous, and you answered my questions, so I want to make sure you're aware of that, Dr. Thalla.
Of course. Thank you.
Yeah. All right. We've probably got time for one more. I know there are a bunch of very personal questions. Please take a picture of this slide so that you have Dr. Thalla's information and you can reach out to him. He's not too far from us. Then I think I'll ask this last one. If someone does need to like take an NSAID for pain, would you, for exercise, like when they're exercising, would you recommend that they take it before or after exercise?
So it depends on when their pain typically arises. If their pain arises with exercise, sometimes taking the anti-inflammatory beforehand is totally fine. You want to be safe with anti-inflammatories. If you're taking anti-inflammatories on a daily basis, you definitely want a physician to know about that. So make sure that they're watching that and make sure that they're watching the strength of the dosing that you're taking and make sure you're not having any underlying kidney issues or stomach issues. Because sometimes people take these NSAIDs for a long period of time and all of a sudden they start to develop these other issues and they were just popping over the counter and anti-inflammatories for years sometimes before we see them. So we definitely want you to definitely tell a physician and make sure that they're monitoring that. But before exercise, it can help you facilitate reduction in pain and facilitate ease of exercise. Sometimes exercise itself can cause inflammation, so that could be a natural way to kind of reduce some of that inflammatory effects of exercise. But if you're getting a tremendous amount of pain from exercise that you're needing an anti-inflammatory every time you exercise, something's wrong. So you got to see somebody about that.
Thank you. Great advice, Dr. Thalla. Yeah. All right, it's all been great advice again. Lots of thank yous out there. I'm sorry we didn't get to every question. They just keep coming in. But we appreciate your time. Thank you all for joining us this evening, and we will look forward to seeing you next year.
All right. Thank you guys so much for joining me.
Thank you. Take care. Have a great evening, everybody. Thanks again, Dr. Thalla.
Of course.